In this case, we might not go fully guided. It is important that we establish the exit point of the screw hole from a restorative point of view. As you know, that we have our axis in the long axis of the tooth so that the screw hole can be on the occlusal surface. In this case, we're going to end up doing two little bridges, so having the implants as parallel as possible helps with the manufacturing techniques and makes sure that we have proper force distribution of the occlusion post-operatively and when the dentition is in function. Alright, with this guide system we make use of keys, and the keys is to facilitate the drills as we are going to use them sequentially in the implant system up to the size of the implant that we are placing. So we're starting off with the guide drill on tooth number 25. The overall length from the top of the guide right to the tip of the implant, overall drill length is 20.5 millimeters. So we just control 20.5 mils, which is just about the complete length of the guide drill. During the process, no bone goes to waste and is all caught up in a bone trap. On tooth number 27, we are going to be very close to the sinus, so therefore 19.5 would be way too deep to go, and we will be ending short by approximately 3 millimeters, therefore 16.5. We'll probably go even shorter than that. Make sure that your guide stent is seated properly, otherwise your implant will be very inaccurate. So we're going to stop short at 15 millimeters. We could rather infracture the bone than perforate into the sinus. So now we need to go to the next size with the twist drills. Drill speed approximately 550. And we drill up to length. Make sure your guide is in place. We know that the most accurate guides are tooth-borne, and therefore we prefer a tooth-borne device. At this moment in time we were working flapless. When you are using guides, it's easier to have a flapless approach because of your planning beforehand. You know where the position of the bone is, and in this instance you will have to trust your guide. At this point in time I have reached the position of the implants and I know exactly where my implants are going to be. I am now going to open up the bone, prepared to final depth and final width of the implant. Elevate full thickness, so clearly visible that there is enough bone on both of the implant sides towards the buccal of the implant. Therefore we should be fine in terms of 2 millimeters outside of the implant, and this area of indentation here will add a little bit of bone there. Since we already have a positioning for the implant and we are not working fully guided, we are okay with the osteotomy to final size now. The implant size at least is 4.5 by 10 millimeters, so we go down to 10, so we'll go about half a mil more. Having prepared the full aperture width of the implant, now it is time to go over to the Versa system and start pushing that bone up to lift up the sinus. So we're starting with 4.3, so that we can go a little bit more, constantly watching our length, see what it looks like on the osteotomy. Still safe from the sinus, about 5 millimeters down the bone at the moment, so we could go somewhat further. Let's just do some bone densifying. Using the Versa system, as you know, it's got a cutting side as well as a bone densifying side, and in order to densify the bone, use the drills in reverse so that we can, instead of removing the bone from the ostomy, actually force it towards the apical part of where the implant is going to sit. So we now have our position of our implants prepared. Both of the implants are at length and at the right diameter. We are now going to place the implant itself. So this is the implant that we are placing. Just open the implant, and on top of the implant is the cover screw, which is hidden behind the white cover, and then as you can see the implant is double packed and it now fits onto the placement head. This is the implant to be placed. Fit the placement head over it, and as you can see it has a nice tight grip. Change the angle and remove the implant. So as you can also see, this is an internal connection implant with a progressive thread and the SLA surface. Implant goes into the osteotomy and obviously turned in, and primary stability at this time feels quite good. Alright, implant number 1 is in position. Let's check position of the implants. Okay, let's go again. So we open our implant, same implant size, undo the top, tip out the implant, fit the placement tool, make sure that it's tight and remove the implant. Bone's quite soft, but the thread is gripping, and we'll stick to that implant position. We'll turn it a little bit more using a force driver. Final position of both implants. So in this implant system, you will note that there's no thread on the placement head. It just pops off. It's got a hex and then the taper fit for the internal fit. Implant position can be seen. So the cover screw has been uncovered and picked up in this fashion and turned into the implant. As you can see, the instrumentation has got a nice grip for finger turning, also an attachment for the torque instruments. Right, here we go again, just to show. Open up, and it's finger tight. So both implants are in position, and they are at bone crest level, clearly visible here, and a little bit of thread sticking out there, which we will now sort out with some augmentation. Positioning of the membrane with a bone tack and another bone tack to follow, indicating the positions of the bone tacks, holding the membrane down. And now we're going to fill our pocket. This is our autogenous bone that was harvested from the osteotomy sites, and we will place this bone underneath the membrane. This is the knife and fork technique, tucking in the membrane on the other side and making sure the membrane is tight. There we are. In this case, in order to get the flap tension free, we're just going to score the side of it to make sure that we can close our soft tissue nicely. Repositioning of the flap, and as you can see, there is some volume in the buccal wall. So we just hope that our sausage-like technique works alright. First quadrant, if we just position the guide stent, again make sure it's firm, tooth number 1/4 and 1/6, full thickness incision, scoring it properly so that we can lift up the soft tissue nicely, and then removal of the soft tissue from the bone. And as you can see, ample bone width. So I would imagine there will be a debate whether I would have had to go flapless rather than lifting a flap here. I would imagine if we were going to go single stage surgery, that would have been okay to not make a flap. However, we know that the position 1/6 haven't got enough vertical height in terms of the bone, and therefore we want to bury the implant to integrate in its own time without intervention and physiological forces, or even pathological for that matter, no forces involved in the healing process. This periost is a bit stubborn. Need to lift it off nicely because we don't want to tear the tissues. There we go. So see that we've cleared distally. We now go guide stent firmly back in place. Seems like we'll be okay. Guide stent keys. So we start with a pilot drill again, and which in this case will be, in this guide stent system, a medium size as well as 2mm twist roll that's going to go in. And again, we know what our overall length is, which is predetermined. Again, on the tooth number 1/7, or shall we say the distal implant, we are talking about 19mm, and on the mesial implant 19.5 as well, up to length. And as we know, we have to go short in this foot. So we have our osteotomy visible, more than 2mm to buckle. Got a lovely buckle wall ridge, and we can place our implant straight ahead. In the case of distal, I'm going to use a tome. This is twofold. One, bit of bone expansion, not that we really need that, but also in fracturing the floor of the sinus. 10mm in length. So to test if the sinus is perforated or not, close the patient's nose and ask him to blow through his nose. So let's go to the next spade drill. Okay. And we know that our implants are 10 millimeters in length. Again, open the implant top. You can see the healing cap onto the placement head, turn out the implant and pick it up, right? To go through the tissue. So we're going to place the distal implant first. And as you can see, good primary stability. And again, just clips out. The placement head of the implant just clips out. So that you can just give it a bit of a pull and check your position. Open up the healing cap, healing screw. The placement tool fits onto the hex driver or onto the implant placement tool. Beautiful primary stability here. So we can turn the torque up slightly. So we need to turn it a little bit more. There we go. The height of the crest. Lovely. Implants in place. Lots of bone towards buccal, even though the implant in the distal end looks quite a bit towards the buccal, but that's following the arch of the lower jaw. Here, all done and dusted, nice and neatly together with one suture. Alright, now we go to lower jaw. So in the guide stent we have a seating window, and the seating window is over here just to prove that it really fits well and that it's seated completely so that we can go and place our implant. We are going to use a key set again to start off with. We know according to our implant planning that it's 10 millimeters by 4.5. We are going to do a two-stage approach transformation of implant length first. Overall length 20.5 mils. So it's a full length of this draw bit. So we have our implant position, slab hang in the middle of the ridge. Now we can make an incision on the crest and really as small as possible. The amount of tissue around here is really easy to generate a nice emergence profile. The implant behind us, old implant, it's been there for just short of 2 centuries. Other than that, approximately 15 years. Very stubborn tissue. Again, as you can see, proper buccal wall, proper attached gingiva. No need to go and fiddle with all kinds of weird and wonderful grafts here. Just place your implant and sort out the tissue with modulation afterwards. Again, position the guide stent properly. Make sure everything is in place. And the next draw size. Again, we're only going partially guided, therefore time to remove the guide and we're down to length. The draw is 1 millimeter too short to reach all the way, and we can place the implant. 30 Newton centimeters, easy fitting, lovely primary stability. Just check the buccal size, and the implant can turn another 2 threads. Nearly there. Yep. All in. Again, nice finger grip and really simple placement of an implant. Alright, let's close up.